So now we know how we got to barbiturates. So barbiturates can be classed according to their relative lipophilicity of the compound. So increasing the lipophilicity of a barbiturate results in faster uptake into the brain and more rapid sedation. So I mentioned before that all barbiturates come from a barbituric acid. So here's the chemical structure here. You can see how that relates to barbitol, which was the very first synthesized barbiturate. And then from there, here's examples of 3 different types or groups of lipophilicity. So we've got phenobarbital, which has low lipophilicity. So that means that it has slow uptake. We've got amobarbital, which is a medium lipophilicity or an intermediate uptake speed. And then we've got thiopental, which has high lipophilicity and has fast uptake into the brain. Okay? Now, why does it matter? So the speed of uptake into the brain can depend or can change the resulting effects the drug has. So barbiturates can change the amount of consciousness that someone is experiencing. So anxiolytic and tranquilizing effects happens at a low dose. So here we see relief of anxiety. We still have high consciousness. Sedation, still pretty high consciousness. You're still conscious. Now, sedation and sleep are about medium doses, or what's called moderate doses. Sedation's like a low moderate dose. Sleep would be a higher moderate dose. And so again, consciousness levels there. You can wake up from a sleep. At high doses, that's where we get our anesthetic effects. So general anesthesia into a coma and even death. So once we get too high of a dose, then if you're not careful, you can fall into a coma and death. Okay? So we've got short-acting and intermediate-acting barbiturates. So short-acting means it gets taken into the brain quicker. So if we go back here, so it's a fast. Okay, so fast uptake would be short-acting barbiturates. So they're going to enter the brain quickly and leave the brain quickly. So short-acting. And ultra-short-acting or short-acting barbiturates are usually used as anesthetics. They are highly lipophilic. An example here would be thiopental. Like I mentioned before with that example, another one would be hexobarbital. These are usually administered via IV to help increase the rapid uptake. So that's why when you're, say, at the dentist getting your wisdom teeth taken out, or you see on hospital dramas that they say, like, count backwards from 10, and people can't usually count the full 10 seconds before they fall asleep, and that's because they're using they could be using one of these ultra-short-acting barbiturates, where uptake and sleep happens in about 10 to 20 seconds. This unconsciousness, this anesthesia lasts 20 to 30 minutes for a single dose. Now, if you're in surgery or something, they're usually monitoring this, and they'll continue to give more so that you stay asleep as long as they want. But with just one dose, unconsciousness lasts 20 to 30 minutes. And it ends due to a redistribution of the lipophilic barbiturates into fatty tissue. So instead of the barbiturates traveling around the brain, they're they get sucked into the fatty tissue. And remember, when things go into the fatty tissue, then they can't act on your neurons anymore, right? We learned a term about what that's called. If you don't remember, look it up, guys. Then we have our short or intermediate acting barbiturates. So these have a more moderate lipid solubility. A great example would be amobarbital or pentobarbital. So here, then sleep takes about 20 to 40 minutes, but it can last for 5 to 8 hours. So you can probably understand why these short intermediate barbiturates have been prescribed for insomnia, because they help you fall asleep and stay asleep a long time. Now, the amount of time that it stays in your body is dependent on liver metabolism, because these barbiturates are usually administered orally. However, barbiturates do have a high abuse potential, especially at these short intermediate acting barbiturates, because you get that sleep. And your body can actually become dependent on these barbiturates and not be able to sleep without them. Next, we've got our long-acting barbiturates. Now, these barbiturates have low lipophilicity, so they're going to take longer to kind of activate in the system, and they're also going to stay in the system longer. So these are the barbiturates that are used and are effective at treating anxiety and seizure disorders. They have a slow metabolism. Again, they're usually taken orally, but they aren't metabolized as quickly as those slow intermediate barbiturates. A great example here would be phenobarbital or methylbarbital. What are the side effects and safety margins of these drugs? Now, we kind of mentioned this in the GABA lectures, but we're going to go over it again. So the anxiolytic effects are accompanied by cognitive side effects, because they are not only anxiolytic, but also sedative. So we've got some mental clouding, loss of judgment, slowed reflexes, everything's kind of slower, kind of fuzzy. Intoxication happens in high doses, which can lead to staggering, jumbled speech, and impaired thinking. When taken too much and you fall into that coma or death, it's due to respiratory depression. Now, another side effect is that they can alter your REM sleep. So it'll increase, usually what happens is it'll increase the amount of sleep you have, but actually decrease the REM sleep. So you're still getting more sleep, but less REM sleep, so less dream sleep. They do produce high tolerance and dependence. So I mentioned that a little bit before, how some people who start taking barbiturates as a sleep aid then become dependent on it, or they'll become tolerant and they'll have to take more and more. So this is where we get that high abuse potential. We also see that the safety margins narrow due to these tolerance mechanisms. So the initial drug use, your safety margin is quite wide, but as you develop a tolerance, the safety margin narrows, because this the lethal dose, the amount of dose that will lead to our negative effects. So if we go up here, so where it goes to coma or death, these are really the negative things. That's where this red line comes to, that respiratory depression. And what you can see is, while our desired effects moves, the respiratory depression line does not. So we have a very low safety margin with barbiturates due to tolerance mechanisms. So I mentioned that it can affect your REM sleep. So let's see exactly how barbiturate use affects your sleep. So despite their hypnotic effects, barbiturates do not induce a restful sleep. So you increase the amount of sleep, but it's restless sleep. Okay? So short-term use, so here's that, will result in rapid sleep onset. So you'll fall asleep quicker. So that's what this green line is how long it takes to fall asleep. And but what it's going to do is you'll have more sleep, but it decreases the amount of sleep in stages 3 and 4. So 3 and 4 is this dark orange and purple. And what you can see is that we only have one instance of purple and very little amount of dark orange. Now up top, this is kind of the normal sleep or ideal sleep. Sleep onset's about the same. But there's a lot more purple and dark orange sleep times, amount of time in sleep, right? Now, we do have a lot of stage 2 sleep, and you can see that the REM sleep, this kind of stage 1 with the red on top, that's the REM sleep, it's about the same as with normal. But in chronic use, so if you become dependent on these, for instance, pentobarbital for sleep, then what happens is not only do you decrease the amount of REM sleep, so here you can see there's only 2 instances and they're very short of REM sleep. You also are continuing to decrease your stage 3 and 4 sleep, so now we don't have any stage 3 and 4 sleep, but you also have spontaneous waking, so you're going to wake up multiple times throughout the night. So it's no longer really useful as a sleep aid. You're not getting as much sleep. It takes longer for sleep onset to occur. So you can see why they're prescribed for short-term use only, and chronic use. You can see kind of how tolerance is happening. We're not getting these same effects with chronic use. Now, increasing the dose may help, restore a bit of that, but overall, you're not going to get the same effects with chronic pentobarbital use. So, barbiturates have also been used or are also used for illicit use, and this is due to their high abuse potential because of the rapid tolerance and dependence. So illicit use of these drugs peaked in the 60s and 70s, again when a lot of drug use peaked, and it's often used in conjunction with amphetamines. So that's because, remember, it's a downer. So they would be paired with amphetamines, which are uppers. So a great example would be people would use amphetamines during the day and barbiturates at night. So they would need the amphetamines to kind of get through their day. They'd be up, they'd be good to go. They're going to work hard. They're going to concentrate, this and that. And then they take barbiturates at night to calm down, to get that sleep, and to not have those effects of the amphetamines. There's also a high potential for interactions with ethanol, so that's alcohol. And decreasing the safety margins with tolerance leads to high potential for overdose. So as you increase your barbiturate use, you're increasing your tolerance, you're increasing the potential for an overdose. In fact, several high-profile deaths were attributed to barbiturate overdose in the 60s and 70s. I think I mentioned a few of them before: Marilyn Monroe, Jimi Hendrix, Judy Garland. The movie Walk the Line actually depicts the withdrawal syndrome of barbiturates.